Just to introduce myself, I'm Helen Brough. It's nice to see lots of people in the room that I recognise. For those who I don't know, I work at St Thomas's Hospital as a consultant in paediatric allergy, and I'm the clinical lead for the service, and I run a joint allergy and respiratory clinic. We're actually doing a specialist allergy and asthma clinic, which we're looking to set up sequence target for. And so asthma is a real interest of mine, and I think it's an area that in the UK in particular we need to be doing well. So I'm going to have a quick chat today about the prevalence, then asthma phenotypes, some of the literature surrounding the link between allergen exposure and asthma, the asthma and other atopic conditions and how they relate. Then I'm going to talk about the National Review of Asthma Deaths, which I'm sure you're all aware of, and then the latest BTS signed guidelines from 2016. So, in the UK, asthma is the most common long-term condition, and about 1 million children are affected with asthma. And this is just a map showing you the parts of the world with levels of asthma, and those that have the little red stars are the ones that have the highest level of asthma. And you can see here that the UK is really full of little red stars. And you can see here, when they look at specifics, so Scotland has the very highest level of prevalence of current asthma symptoms in childhood, followed by Jersey, then Guernsey, then Wales, then the Isle of Man, and then England. So really, we are right at the top of all of the different countries for asthma. We don't really know why that is. There's a few hypotheses, but essentially it means that we need to be managing our asthmatics very well. One of the good things is that this is another study which looked at time trends of various atopic conditions, and the little blue downward facing triangles show that the prevalence is reducing. And you can see here that the UK has lots of little blue triangles. So actually, since the late 1990s, this steep rise in asthma symptoms that we were finding has actually plateaued. We are still seeing a rise in various other atopic conditions, but for certain in asthma, it has reduced. So, chatting about the asthma phenotypes, you can see here that there are allergen-induced versions and non-allergen-induced versions of asthma, and then intrinsic asthma, which the main gene for this is ADAM33. The majority of asthma, as you will, I'm sure, see in clinical practice in children, is allergen-induced, and that is in children that have a positive allergy test to one of the common allergens, such as the aero allergens, but also maybe food allergens. So in here, house dust mite, pollen, ragweed, cockroach, and mold were those defined. In the non-allergen-induced forms of asthma, this is more common in adults. So ozone, cigarette smoke, diesel particles, infection, aspirin, exercise, and cold air, although this can also affect children. And this is just a more detailed schematic picture of the different types of asthma phenotypes. And you can see here that in childhood, the most common is allergic asthma, and then in adulthood it becomes more of an obesity-associated, smoking-associated, or smooth muscle-mediated. So, in children in particular, allergic asthma is the most common form of asthma. However, the issue is that many of the symptoms of allergic and non-allergic asthma are the same, so unless you have some form of testing, it's difficult to tease these out. And it is important to know about whether your child has allergic asthma, because then you can identify some of the triggers. Because allergic asthma is triggered by inhaling certain allergens. So, we know that if you inhale house dust mite and you are allergic to house dust mite and you have asthma, that you're going to have an increase in asthma symptoms, and also you can have objective scores on challenge testing. However, do we know whether allergens actually drive the pathogenesis of asthma? So there's been a lot of work looking at risk factors for the development of asthma, looking at indoor allergen exposure, and the risk of allergen-specific sensitization, such as house dust mite, and then the risk of asthma. And certainly children who have higher levels of house dust mite around the time of birth have an increased predisposition towards asthma. However, as you probably know from the Manchester Asthma and Allergy study, reducing exposure to house dust mite using the various environmental ways that they didn't actually reduce the incidence of asthma. Actually, it was counterproductive. So, we have a bit of a bind in terms of knowing about risk factors, but actually the intervention doesn't work. It may have to do with the bell-shaped curve, so essentially if you're moving all the people who are in the middle range to the lower range, then you're protecting those, but if you're moving all of those that are in the very high range to the middle range, then actually you're doing a disservice to those children. Also, there's lots of more detailed interactions and subgroups of people that need to be assessed when you're doing these types of analyses, because it depends on your genes as to how you respond to an intervention, and it also depends on the other environmental factors. So, for example, we know that there is a very strong association between endotoxin and house dust mite. So, for example, in the Manchester Asthma and Allergy study, they reduced the amount of house dust mite by doing all of these measures, strict washing, covering the bed, lots of different HEPA filters, those types of things. However, they also reduced endotoxin, and endotoxin actually is protective against the development of asthma. So you have to think about other environmental aspects. There's also the genes, which I mentioned, and there are interactions between different types of genes, for example, the lipopolysaccharide receptor and endotoxin. So depending on your genes will depend on how you respond to certain environmental factors, which is why probably when you do overall studies, it's much more difficult to find convincing results. So, I've mentioned this, house dust mite reduction measures did not prevent asthma, and it was mainly the Manchester Asthma and Allergy study that showed that. How about house dust mite reduction measures in house dust mite sensitized individuals for symptom relief? So for asthma, actually, there is no evidence that this works. For perennial allergic rhinitis, if it's done in an extensive manner, there is some evidence that it works. And with regards to pet dander, there is actually no trial looking at stringent environmental controls which have benefited or reduced asthma symptoms. So, I'm sure this is what you see in your clinical practice. We have a child who presents initially with eczema, then they start developing their food allergies, then they grow out of their eczema and perhaps grow out of their cow's milk and egg allergy, and then start developing allergic rhinitis and allergic asthma. And we know that all of these conditions are interlinked, as called the allergic march. So how do they actually impact on each other? So firstly, I'm just going to talk about the risk of atopy and allergic disease and asthma. So if you have more positive allergy tests, you are much more likely to have various different forms of atopic disease. So if we look here at the asthma one, which is the little diamond, third one along. So as you increase the number of positive allergy reactions, you also increase the percentage of asthma prevalence. And similarly, for if we look at the small circle, which is any allergic disease, so right at the top, obviously this increases. So there is a link between allergic sensitization and all forms of allergies, including asthma. It was interesting, however, when they looked at which specific allergen was more susceptible to increase asthma. They found that house dust mite, as I mentioned already, was a risk factor for asthma. They also found that grass pollen was a risk factor for rhinitis, and you could expect this really because these are aeroallergens. However, they also found that egg sensitization was a big risk factor for rhinitis, and we also know that egg allergy means that you are at a much more increased risk of asthma later on in life. So there's a link between food allergy and respiratory allergies as well. So we know that if you have eczema, you have a much higher risk of developing asthma, and children who have eczema also often have egg allergy. So if you have those two and you have maternal asthma, you're almost certain to develop asthma later on in life. So it's something to really make sure that those people are the people that you continue to monitor in your clinic. So this is just a string of different studies looking at the prevalence of asthma in children who have eczema. And you can see that it ranges from between about 14% up to 50% up here. So what about food allergy and asthma? We know that the children who have food allergies can also develop asthma, but it was very nice in this study that they looked at this in detail. So they looked at children under 6 years of age and at children 6 years or older, and they looked at the number of food allergies in these children and then to see whether that increased the risk of asthma. So under 6 years of age, you can see here that if they had one food allergy, they had a 29% risk of asthma with an odds ratio of 5. If they had more than one food allergy, then they had a 36% risk of asthma. So these are numbers that you can quote to your patients. In children who are over 6 years of age, similarly, it was higher, but you can see here that it was even higher than in children under 6 years of age, with a 53% rate if you have one food allergy and 75% rate if you have more than one food allergy. What about severity of food allergy and asthma? So here you can see under 6 years of age, if you have non-severe non-severe food allergy, the chances of asthma 24%. If you have severe food allergy, the chances are 36%. However, over 6 years of age, it goes to 51% with non-severe food allergy and 68% with severe food allergy. So again, this is something that we need to think about in all of the children who have had anaphylaxis to any food. So we know that the link between food allergy and asthma, but also we know that if you have a food allergic reaction, you can have respiratory symptoms. So 50% of food allergic children have allergic reactions involving their respiratory symptoms. However, also 40% of all food allergic reactions have respiratory components, and we know that certain foods can cause allergic symptoms if they are aerosolized. So for example, if you have a child with fish allergy, they're very likely to have allergic reactions if somebody is cooking fish in the kitchen. Similarly, that can happen for egg. So you're aware of this, but this is really quite striking when you look at the numbers of fatal or near-fatal anaphylactic food reactions associated with asthma. In the orange columns are the children with asthma that had fatal or near-fatal anaphylaxis, and in the blue columns are the children without asthma. And you can see that almost universally, the children that had fatal or near-fatal anaphylactic symptoms were those, or features were those with asthma. So anaphylaxis and asthma are two sides of the same coin, and I am quite aggressive in managing asthma in children that have severe food allergy. So what about allergic rhinitis, or the unified airway? So how does that impact on asthma? So we know that asthma is increased in children that have allergic rhinitis. This is from a US population, because actually in the UK there's much more asthma than that. But yes, in this group, 19 to 38% of children with allergic rhinitis had asthma versus 3 to 5% in the general population. However, they also found that allergic rhinitis is almost always present in asthma. And I do get quite a lot of children that are referred from respiratory clinics that are on a very, very high levels of asthma treatment. And they also have allergic rhinitis with completely blocked noses, but that is not being treated. So I'm always thinking about allergic rhinitis whenever I see a child with asthma. And we also know that if you treat allergic rhinitis, that it increases so if you have allergic rhinitis, it increases your risk of asthma severity. So you have a 3-fold risk of frequent wheezing attacks and a 10-fold risk of frequent GP visits for asthma. And also that treatment can help your asthma control. So what about the prognosis for childhood allergic rhinitis? So this is a study that looked at children that had either seasonal allergic rhinitis or perennial allergic rhinitis at the beginning of the study, and then they followed up these children for 10 years. They looked to see whether they developed asthma. So you can see here, these are the children with seasonal allergic rhinitis at the beginning. After 10 years, 70% of them still had seasonal allergic rhinitis. So actually that's quite nice, because I often tell patients that have allergic rhinitis that the chances of them outgrowing their allergic rhinitis is very small, but actually in this group, 30% had outgrown it. Then perennial allergic rhinitis can emerge. The seasonal allergic rhinitis children had developed asthma in about 12%. However, in the perennial allergic rhinitis group, there were far more children that had developed asthma. So in the children that have perennial allergic rhinitis, they are the ones that are more likely to develop asthma over time. In this study, it was 33% of children that developed asthma over 10 years. When they looked down not just at the actual symptoms, but at the pollen or pet dander or house dust mite allergy, they also followed these children up in a separate study to assess whether they developed asthma. So in the group that had allergic rhinitis at baseline in blue versus in the group that did not have allergic rhinitis at baseline in orange, you can see what happened depending on what you were allergic to. So those that had allergic rhinitis and were allergic to pollen over 8 years had a rate of 12% development of asthma with an odds ratio of 8. For pet dander, it was an increase of up to 20% or 17% with an odds ratio of almost 19, but house dust mite was far more risky with regards to developing asthma, but only if you had allergic rhinitis symptoms. So if there was no allergic rhinitis at baseline and you just had a positive allergy test, then it actually didn't increase your risk of asthma. So I mentioned about treating allergic rhinitis and that can help with your asthma control. So this was a study of about 4,000 children, and they looked at treatment of allergic rhinitis in these children versus no treatment. And they found that those that had been treated for allergic rhinitis had a lower risk of asthma-related A&E visits and a lower risk of asthma-related hospitalizations. And actually 47% of those that had been treated for their allergic rhinitis did not have an asthma-related event and had a reduction in hospitalization by 61%. So what about immunotherapy? This is the results from the PAT study, where they looked at around 200 children, and they looked to see whether specific immunotherapy to pollen could reduce the risk of asthma after the 3-year treatment course. And they show that there was actually a 2.5-fold reduction in asthma in the children that had received the specific immunotherapy versus those that had not. So in orange, you can see those that had asthma, and in blue, those that did not have asthma. So over the period of time, if you had specific immunotherapy, the rate of asthma here was much lower, so 25% versus controls, which was 50%. So this is all the literature, but going back to much more practical clinical things, in the UK, there was the National Review of Asthma Deaths between 2012 and 2013. And the reason that this review was done was because it was noted that although the UK rates of wheeze were higher than the rest of the world, actually our mortality was even higher in proportion to the rate of asthma symptoms. And also, it was noted with the Atlas of Asthma that there was a very big variation in practice for asthma and a big variation in asthma admission rates, so between 26 and 642 per 100,000 children, which is a 25-fold variation, which suggests that there is variation in practice. So the National Review of Asthma Deaths found 195 deaths in the year of 2012 to 2013. And they found that what was associated with those deaths was excessive prescription of reliever medication, inadequate prescription of preventer medication, inappropriate prescribing of long-acting beta-2 agonists, and so this is your green Ceravent inhaler being prescribed without corticosteroids or just being prescribed at all. I actually don't recommend it being prescribed at all. If you're going to use a long-acting beta-2 agonist, it should be combined with an inhaled steroid and not prescribed on its own. Of those that died, only 23% had a personalised asthma action plan, and we know that a personalised asthma and action plan reduces the risk of hospital admission fourfold because it tells people what to do when they are out of hospital. So specifically looking at children, there were 18 deaths, and the majority of children died before reaching hospital, which is why it's so important for parents to have the personalised asthma action plan. 8 out of 10 were aged under 10 years of age, and 13 out of 18 were aged 10 to 19 years. 43 of these had been managed only in primary care, so were considered to have mild asthma. And it's interesting in terms of allergic asthma that many of those that died between the ages of 10 and 19 years, when allergic rhinitis is more common, died between March and September, which is when you have your tree and grass pollen allergy. And 39% had known allergic comorbidities. So what were the recommendations? So the recommendations were that all children should have a personalised asthma action plan. Essentially, what this does is it details what the treatment is for the child, it details what their triggers are, and also it tells them what to do if they're having an exacerbation and how to seek help. Again, reviewing these children at least annually is really important, and if that's not something that can be done in your allergy clinic, then it needs to be done either locally or if it's mild asthma through the GP. And at that point, each episode of review needs to have a structured approach with an inhaler technique training, compliance review, and a discussion about minimizing exposure to allergens and smoke. So we know from the National Review of Asthma Deaths that more than 12 reliever prescriptions was a very strong risk factor for death. So this should trigger urgent review in anybody who needs to have this, and this is something that GPs are much more easily able to pick up. And then really importantly, and I do this now with all my patients, is explaining to them how their asthma medication works and why they should be using it, because the parents are the ones that are often administering it to the children, and they'll only do it if they understand why they're doing it. So out of the National Review of Asthma Deaths came the NICE quality standards and these quality statements in 2013. I'm just going to run through these, and you can think about how they apply to your own practice. So newly diagnosed asthmatics should be diagnosed using the new BTS sign guidance, and I'm going to go through that in a minute. Adults with new onset asthma should be assessed for occupational causes. People with asthma should receive a written personalized action plan. Training and assessment of inhaler technique should be done before starting any new inhaler. People with asthma should receive a structured review at least annually. People with asthma that develop respiratory symptoms should have a review of their asthma control at that time. Asthmatics that are having an asthma exacerbation should have some form of objective asthma severity reviewed, whether that's an asthma control test, peak flow, or spirometry. Children more than 5 years of age with severe asthma exacerbation should get oral or IV steroids within 1 hour of their exacerbation. People admitted to hospital with an acute exacerbation of asthma should have a structured review by a member of the specialist respiratory team before discharge. People who receive an out-of-hours service for an acute asthma exacerbation should be followed up by their GP within 2 working days. And then those children with difficult asthma should be assessed in an MDT difficult asthma service. So sorry just to go through the list, but it's actually really clear what we need to be doing, and there's a lot of manpower that's required for this. So it's something that has to be business planned for and something that has to be actively initiated, because it's not something that just happens on its own. So these are the new BTS and signed guidelines. So there's quite a lot of differences in the new guidelines that came in September 2016. And there's a lot of focus on symptoms, because actually history is the core of all our medical practice, and actually it has been shown that of all the different ways of assessing patients, actually the symptomatology is the most accurate way. So a structured clinical assessment looking at wheeze, cough, breathlessness, chest tightness on history taking, and the recurrent episodes of these symptoms. Symptom variability, absence of symptoms or alternative diagnosis, this is at the top. Recorded observations of wheeze, so if they've seen their GP or coming to A&E, personal history of atopy, and then a historical record of variable peak expiratory flow, or FEV1. And actually there's quite a lot of focus on peak flows in the new BTS sign guidelines. So if you go through this and you think that the child has a high probability of asthma, then you start treatment. So in this situation, if there's a high possibility of asthma, you start treatment without needing any further investigations. Then you need to bring them back and assess their response objectively with lung function testing or validated symptom score such as the asthma control test. If they have a good response, then they have asthma, and then you can manage them as asthmatic with self-management advice and a personalized asthma and action plan. If they have an intermediate probability of asthma, then there's lots of different tests that they recommend. So the test is for reversibility, so bronchodilator response on spirometry, and anything above 12% is considered a positive BDR, bronchodilator response. Peak flow charting, so doing that over 2 to 4 weeks, and then looking for the mean variability, so anything above 20% variability is considered positive. And then challenge testing, which we don't usually do, but this consists of things like mannitol, methacholine, and exercise challenges. Testing for eosinophilic inflammation or atopy, so exhaled nitric oxide is also in the guideline now, as well as blood eosinophil skin prick testing and IgE, although they don't recommend doing the skin prick testing IgE or blood eosinophils in most patients. So following all these investigations, if they have suspected asthma, then you can either do watchful waiting if they're asymptomatic, or you can commence treatment and assess the response objectively. And with commencing treatment, they define that as using either very low dose steroids, which is a total of 200 micrograms of beclomethasone equivalent per day, or low steroids, which is an equivalent of 400 micrograms of beclomethasone per day. So, low probability of asthma, you do some investigations and you consider other diagnoses. So it's a really nice figure and goes through all the different potential aspects. So what are the accuracy of all these ways to assess our patients? So as I mentioned, the best way to assess the patient is through their history. 2 out of 3 children with cough, wheeze, chest tightness, dyspnea and exercise symptoms have asthma. If they don't have one of these symptoms, then the chances of asthma goes down quite dramatically. Now, we all know that we've seen lots of children with terrible asthma that have a normal spirometry, and we've also seen children who have no asthma that have awful spirometry. So you have to think about the technique of the child, and you have to have somebody who's experienced doing the spirometry assessment. But still, you'll find that there's children who have a positive bronchodilator response that have no asthma, and there's children with a negative bronchodilator response that have got asthma. So 1 in 3. The spirometry FEV1 over FVC ratio of less than 70% is considered to be a marker of obstructive airways disease. However, more than 50% of patients with normal spirometry with using this marker will have asthma. And that's because they're asymptomatic when you assess them, which is why in some ways the peak flow is better because it does a 2 to 4 week period. Exhaled nitric oxide, the SIGN guidelines define positive exhaled nitric oxide as more than 40 parts per billion in adults and more than 35 parts per billion in children. However, again, in adults, they didn't mention about children. They showed that 1 in 5 adults with a positive exhaled nitric oxide have no asthma, and 1 in 5 adults with normal exhaled nitric oxide do have asthma. So essentially, all of the tests that we do are not fantastic, and the best thing that we have is our clinical history. We have to use a combination of clinical history and testing to make these assessments. Okay, now this is the new treatment algorithm for BTS and SIGN, and I'll just go through this with you. So they've got a diagnosis and assessment stage, which is here, where consider monitored initiation of treatment with very low, that's 200 micrograms of beclomethasone per day, or low dose, that's 400 micrograms of beclomethasone per day, and to review them using objective measures of response, so asthma control test or spirometry. And this treatment now is quite nice in that it includes not just children aged 5 to 18 years, but also under 5 years. So it's all inside one diagram. So once you've decided that they do have asthma, you either use a very low dose inhaled corticosteroid, or if they are less than 5 years old, you can consider using a leukotriene receptor antagonist, such as montelukast. After this, you've got initial add-on preventer step. So you have a very low dose inhaled corticosteroid, plus in children over 5 years of age, an inhaled long-acting beta-2 agonist, and in children under 5 years of age, a leukotriene receptor antagonist. This is then the next step. So additional add-on therapies. So if there's no response to long-acting beta-2 agonists, you stop this and increase the dose of inhaled corticosteroids to low dose. It's 400 micrograms per day of beclomethasone. If there's a benefit from the long-acting beta-2 agonist, but the control is still inadequate, you can continue the long-acting beta-2 agonist and increase inhaled corticosteroids to the low dose, or you can just continue the long-acting beta-2 agonist and keep the steroids at the same dose and consider a leukotriene receptor antagonist. And then the next steps are increasing inhaled corticosteroids to medium dose, so that would be 800 micrograms of beclomethasone equivalent per day, adding in theophylline, and then the sort of considered at this point is the step 5+, where you have frequent use of oral steroids. So I think this is a nice diagram. The only thing is it's sort of a move away from step 1, 2, 3, 4, 5, slightly different, but it does have less than 5 years and 5 to 8 years, all within the same diagram. So to summarize, the UK has the highest prevalence and the highest morbidity for asthma. So it's really important that we're getting it right in terms of our management. We know that allergens induce asthma, and so we can speak to parents about that, but we don't know whether there is a causation, because when we do intervention studies, such as reduction of house dust mite exposure, it doesn't work. Asthma comorbidities, as I'm sure you're all doing, it's really important to screen for all other atopic conditions in a child that has one of the atopic conditions. Firstly, if you have a food allergy and you have well-controlled asthma, you're much less likely to have anaphylaxis and with respiratory symptoms if you do come across your allergen. And if you have allergic rhinitis and asthma, then if you treat the allergic rhinitis, you can reduce asthma exacerbations. Personalized asthma action plan reduces the need for asthma hospitalizations fourfold, so we should be trying to do this in all our asthma patients. And then we've talked about the nice quality standards which we can all take back to our own practice and consider the new BTS sign guidelines. Thank you very much.